So thank you everybody for coming. My name is Victoria O'Neill. I believe I've connected or have some kind of communication with all of you thus far, but for those of you who may not know me, just a brief introduction about myself. My name is Victoria O'Neill. I'm a program coordinator at the Hub, and a lot of my efforts or focus is surrounding suicide prevention and postvention. And because of that, I work very closely with Giovanna surrounding the Regional Suicide Advisory Board. So I will be kind of leading this meeting, but Giovanna, as always, please feel free to step in if I'm forgetting or missing things. So I will share the agenda. And if you don't mind, I'll just putting your just name and affiliation in the chat. That would be great just for attendance purposes. All right. And then just to continue on, if there are any updates, I kind of have some stakeholders identified in section 2 of the agenda, which we can go through each individual kind of stakeholder in a few minutes. But if anybody has any particular updates that they want to highlight now, feel free to come off mute and vocalize that or just put it in the chat. So I'll give it just about a few seconds in case anybody does want to come off mute and share any updates. They can feel free to do so at this time. All right, so just to continue on, I will be giving a brief update with the Connecticut Suicide Advisory Board. They met yesterday and I was in attendance for that. It was a great presentation. They had Caitlin Brown, Brian Hatch, and Jeremy Wampler, all kind of from different sectors, but basically talking about gambling addiction and how it intersects and connects with suicide. A really great presentation. I did just write down a couple quick statistics. I also don't know if I said this, but as I'm sure many of you are aware, this month is Problem Gambling Awareness Month. So that was a real reason why that was the focus of the Connecticut Suicide Advisory Board. But just some quick facts, because for me it was interesting. 8% of people in the state are at risk of developing a problem with gambling in their lifetime. They're up to 50% of people in treatment for a gambling up to 50% of people in treatment for a gambling disorder have suicidal ideation, and about 17% have attempted suicide. So again, just really reiterating that connection, unfortunately. And then there were resources shared out, which I can put in the chat, but there is a call number, which is 1-888-789-777. You can also text CTGAMB, G-A-M-B, to 53342. And then there's also a live chat option as well. And I will, at some point in the meeting, I'll put all those kind of resources and chat lines and call lines in the chat, so you guys can have those to refer back to as well.
You can also go on to the hubct.org. We have updated our problem gambling tab with that information and other resources for you to either learn more about gambling and how it can be a co-occurring disorder, and what treatment providers are in our region that can support you or a client or consumer that you are working with or family member, right?
Yes, definitely. So that was really the update in terms of the Connecticut Suicide Advisory Board, like Giovanna just mentioned, and I have kind of also mentioned really strong connection between problem gambling and suicidality, suicide ideations, and suicide attempts, and something to be aware of, obviously all 12 months, but specifically in March because it is Problem Gambling Awareness Month.
So a lot of so statewide, we are really pushing awareness around problem gambling and gaming, as everyone knows that it is legalized now. And just in the first month of being legalized, they saw a $1.3 million revenue, which that is a lot of money just for 1 month. What I am hearing from our region is that the text line and the call center has had such an increase in calls regarding having issues with gambling, feeling very vulnerable, especially with our college students. college students are calling the line saying that they just maxed out their parents' credit card. So we're learning more, we're hearing more. Margaret's here too, and I know Positive Directions also is a treatment provider for problem gambling. So, and I'm sure she's been hearing a lot too. So just keeping that in mind, our region, for the next month, our hub newsletter is going to be dedicated to problem gambling, gaming, co-occurring disorders around problem gambling. So if you want to get more information and education and just spread the word, please, if you're not subscribed, subscribe to our newsletter. But also our region has multiple events happening all month long, even statewide. So if our dates and times don't work, you can check out another RBHAO's website to get that information. But we do have that, those flyers and things not only in, it is in our newsletter, so you can get that information as well. And anything that for the last week or 2 weeks, you can also get on our website in the archive section. Margaret, we can't hear you.
Hi, everybody. Sorry, I'm getting over laryngitis, so I hope you can hear me. Two things. One, Giovanna, did you say they made $3 million in the first month?
1.3.
$1.3 million in the first month of legalized gambling in this, or online. And do we know what % of that is of the state revenue is going to go to prevention?
We do not know that yet. We did have a conversation with Problem Gambling Services. It's a DEMIS division program, and they are working on really advocating for more dollars.
Yeah.
So right now,
because I feel like it could be, so maybe that's something we should all be thinking about for like the next legislative session. Because with that level of money coming in, I mean, I know they expect a ton of money ultimately, but for that much in the first month, and for the increase in calls about problem gambling, especially if it's an increase from college students who are already at such high risk for suicide, and then gambling is the addiction with the highest suicide rate. So it's like the money should be used not just for preventing gambling, but like there's going to be a lot of money. So maybe we can kind of work with the state to say, some of that money goes to gambling efforts and some goes to suicide efforts specifically, just to try to build the coffers everywhere.
That is, from my understanding, our next meeting with DEMIS is to talk about that, because currently under our initiative, we receive from DEMIS specifically to provide problem gambling resources, education, awareness. We receive $42,000, and that is contracted through Ingrid Gillespie, who works for Liberation Programs. So $42,000 is nothing compared to what our community is dealing with at this point, and the calls. So that is going to be our next conversation, to hopefully let's increase that, this initiative dollars, and let's hire somebody full-time to do some prevention work within our communities.
And because that's for the region. And then
correct.
For comparison, since this is the RSAT, how much money is the RBHAO, is the hub getting now for suicide prevention?
For suicide prevention, education, awareness, and post-prevention response, currently, we only have one contract from DCF working with youth under 18 years old, $80,000.
80,000, but for youth, okay. Is that a one-year thing, Giovanna?
That is supposed to be an 18-month thing, but unfortunately, contracts have been held up. So we've been, again, working. Victoria was hired back months ago, thinking that we were getting a contract back in October. right? Was it October? And we still don't have a contract. So yeah,
And so that'll come through, Victoria. The state is insane. They'll like make you float, they'll make the nonprofits float the money for months and months, but it'll eventually come through, so don't panic.
yes.
But Giovanna, so I was wondering if the state ever provided the RBHs with additional money for suicide. So for the other people on the call, in case you don't know, like suicide prevention in the region has typically been unfunded, but what, 2 years ago, Giovanna, the state gave each RBHO
$10,000.
20, right? Was that what you said?
10.
Oh, I thought
20
it
was for CACs.
Oh, 10.
10.
Okay, and that was through Demas, and so now that's gone?
Yeah, that was.
So
I think that was spent on our post-pension plan, post-pension training.
So totally gone. So totally gone. Okay. So I think that's something important.
And I
for
want to
everyone
just
know.
I want to correct myself. DCF, $100,000. That is our active. Forgive me, it's not 80. We were supposed to receive 80 from Demas, but that contract has not fell through yet. So right now we only are working with $100,000 for 18 months. That started January 1, 2022.
And I don't think it's at the bottom of the agenda, but I don't know if we're going to talk at all about the public hearing on the Suicide Advisory Board coming up on Tuesday. Are we going to talk about it?
I will talk about it in updates because as everybody saw my email last night, it was late. So there are some things I'd like to just kind of talk about and discuss and see who's going to be testifying and or submitting testimony. So.
Okay, because I think that like when we're talking about talking points for that testimony, this is one of the things that we should all be building in. And I mean, with all the public hearings that have been about mental health crisis and all this stuff, the fact that there's no money for suicide prevention at the regional level anywhere is ridiculous. And then so it sounds like you have, but theoretically you would have 180,000, but that's all time limited and it's not actually here. And that's after years of never having anything other than $10,000 one time. Like, I don't think this is stuff that people understand, right?
That's why sometimes I just don't bring it up.
Yeah, but I'm like,
it can be complicated.
Like now's the time.
Complicated.
Right, but you know, it's like, so I'm like, you and I know this stuff and I didn't know how much the hub was getting now. I know how we never got anything in the past. But like everyone here, like there's a public hearing on Tuesday on the Suicide Advisory Board. It's not specifically about this, but these are the times that we have to testify about things like this. I'm done, sorry.
You're all good, Margaret.
So I also just have AFSP, my friend Abby, and Alternatives to Suicide support groups. I don't know if anyone from I can't see who everyone is that's on, but I don't know if anyone from AFSP is on right now. If not, I can go to my friend Abby for an update. If
no, Danique is not here today.
Okay.
Good morning, everyone. I didn't realize I was doing an update, but I should have known. I've missed the Connecticut Suicide Advisory Board meeting. I missed TPOD's meeting. It's been a busy week for us, so I apologize to everybody. I'm really bummed. I mean, I get to this point where I have to do things, you know, like get thank you notes out the door. So I feel bad I miss all these meetings. Yeah, I've been telling a lot of people lately, we're not a crisis organization. So there's just seems to be a lot going on, whether it's parents calling me, kids calling me. So I so appreciate the resources that you guys have. And I do try to, you know, make sure and get the word out. Like if I see Positive Directions doing, you know, young adult meetings and things like that. So what else? Just on the my friend Abby front, we have been working more with teachers just in applying for grants, which has been really cool. It's nice to see that, you know, the whole mental health discussion is happening within schools. I don't think people have a choice on that. So our grant deadline is coming up March 15th next week. So we do 3 rounds of grants every year. Again, they're smaller grants right now, between like $100 and $600, but it's been great to see the young adults applying and wanting to open up and talk about mental health and suicide prevention. It's just here. It's not going away. Other than that, I know, I think Kirsten's on and Leah's on the call. I've been involved in SOS meetings that Trumbull has been having with the Sherlock Center. We've been doing those, and also we've had some post-prevention meetings, which hopefully these guys will talk about a little bit further. And then again, my friend Abby is a sponsor of the Let's Talk series that was created thanks to TPOD.
Gillian, can you just talk briefly about I only know of two people that have received your grant in our region, one in Norwalk and one was in Wilton?
Yeah,
Weston?
Wilton, Norwalk, Trumbull.
Can you just talk a
Fairfield.
little bit about what they did and what they're implementing in their
Sure.
towns, please?
Yeah, sure, absolutely. Just as quick examples, one girl started a baking club with at her home and had, again, this is high school level, freshmen. Started a baking club, had 20 students involved. This is still around the whole, epidemic time. And it was so popular. It was called a cultural baking class. So baking is good for your mental health. That was kind of the theme. And it was all new kids that had never met each other before. So connection is protection, making those new connections with students. Now she wants to start an official club at the high school, which is really cool. We had a young adult teacher from Wilton who had a child die by suicide last year and created something kind of like a safe space within his classroom with letter writing back and forth. He paired up students, and this is all with the permission of the principal. Again, so grateful to see that schools are getting involved and not turning a blind eye. So we had another journaling school that was the one in Norwalk, with kind of some problematic kids, start a mental health journaling daily, I think, daily journals. And again, these are kids within the ages of 10 and 15. So a lot of creative projects, a lot of creative things tied in with mental health and suicide prevention. Does that help? There's a lot, but
I saw your newsletter and I saw your newsletter. Victoria, can you put others on besides myself and Gillian? I saw your newsletter and saw that you had a couple of grantees from our region, and I was just really happy, and I did share that in our newsletter to show not only the great work that our community stakeholders and residents are doing, but you and my friend Abby and all that you do offer. So I really do appreciate that.
Oh, thank you. Yeah, we're trying. It's we're tiny. And sometimes, like I said, it's, I'm not complaining, but yeah, there's always a lot going on. As a matter of fact, I was inundated for the last couple of days. All of a sudden I started getting these emails from students wanting grant applications and wanting to volunteer, and we don't have regular volunteer opportunities. We have some, but not on a regular basis. So I ended up reaching out to the teachers to see what we could do. It was 2 full classes reaching out saying, I'd like to apply for a grant. I'd like to. So again, being our organization, I'm now coordinating with the 2 teachers. And so that'll be something that, they have to go through the whole grant application process. We, everything is vetted through our clinical advisory committee as well. So if anybody has any questions, please let me know. But, we're in our 2nd year. So we're doing what we can, doing what we know right now. So
yep, you're doing a great job.
Thank you.
Gillian, can I just say, when you were saying you have people who want to volunteer, so you're not talking about like kids who want to do grants, but they want to volunteer with the organization. And
Yes.
and so when you said that's not necessarily what you do, like, please feel free to send them to turningpointct.org, right? Because then there's no adults, right? It's 100% teens and young adults. It's all around mental health and somewhat substance use. And the whole intention is for people to use what's going on in their lives, share podcasts, videos, art, blog posts, et cetera, appearances at schools, and it is statewide. So then if they, we can always use volunteers. um, And, um, and then they have an audience potentially around the state, right?
Absolutely. I have recommended you guys so many times. And I think that, again, it depends. Like, so we do have regular campaigns now, again, going into our second year. But for 10-year-olds, 11-year-olds, it's a little bit tougher. But yeah, I know I recommend you guys all the time. And absolutely love what you guys do.
Actually, when you say the 10, 11, so just while I'm talking about Turning Point CT, if anyone doesn't know it, check it out. You can get a weekly, every Friday, Kaylee sends an update with like, here's the latest content that we posted, here are opportunities for young people. So I think Gillian, like when you have your grant cycle, I think she throws that in there, but if not, make sure she gets the flyer. And it'll be like, who wants to do a podcast on this or that? But in terms of social media, one of the social media that Turning Point has is, Turning Point CT has is a Discord. So when you mention like the younger kids, a lot of times Discord is where they are.
Okay, yeah, no, that's great. Thank you. And I love the fact that we're getting younger kids involved. That's our goal. That's our mission, to make sure. And sadly, Abby's friends who helped me kind of start this organization are 23, 24, getting engaged. It's kind of sad for me, but again, our goal and our mission is to make sure that we start talking about all of this starting at the age of 10. Thanks.
Yeah, thank you so much. And then I know there was the discussion of alternatives to suicide support group. You guys want to talk about that really briefly?
So that's our agenda item. Ally had a meeting until 10:30. So if it's okay, like I want Ally Kernan got trained as an alternatives to suicide facilitator, and we want to start a group in the region. And, but we want to get some feedback from you guys when she gets here, if we can let her settle in for a few minutes and then like have her ask the questions. And we're all excited to hear Erin's data and have the latest data and all of that. But,
yeah, sure. We can do that at the end, kind of, or closer to the end. I don't know if there are any other stakeholder announcements. I know last in the December RSAT meeting, we kind of talked about having, instead of doing like a separate meeting specific to postvention, just kind of having postvention as just an ongoing kind of spot on the agenda, so people could give updates if there are any, just share out resources if they do have those. So I don't know if anybody has any updates on specific to postvention that they want to discuss. But
I have other announcements. It's not postvention because I also saw postvention twice on the agenda. I wasn't sure, but just other mental health, suicide prevention related announcements. If you guys aren't getting our emails from either Positive Directions or the towns that we work with, just to let you know, we are starting an anxiety support group for high schoolers, and it's free. It was going to start next Wednesday. It's Wednesdays from 4 to 5 p.m. It's good. It's been pushed back a week. We only have 4 kids who've signed up so far, which is good. We can start a group with 4, but we can also go bigger than that. So please help spread that flyer around. We are sometime in the next month, we're starting a support group for teachers. That will also be free. We had run a teacher support group earlier in the pandemic because it was so needed. And so we're going to bring that back. In terms of just suicide. Oh, and one other thing that we're doing for anyone who's in Norwalk, either as a resident or working in Norwalk, we're bringing back the mental health walk that we used to do regionally. Like that when it was, look at Giovanna's face, she's like, wait, remember Fairfield County Walks for Mental Health. But this year we're doing it as Norwalk specifically, hoping to get a ton of teens and NCC students, but also the whole community. And it'll be a walk and a resource fair. So G, I'll send you the provider survey about that for the hub. But that'll be May 17th, rain date May 14th.
Awesome.
In terms of some suicide work that we've been able to do, one is that we were able to go do professional development days in Norwalk High School and Brian McMahon High School through our work with the Norwalk Partnership, which is the Prevention Coalition. And so we shared all the data we got from our youth survey with them, talked a lot about suicide, talked about suicide trainings and concepts. Previously, Danique and I had done suicide prevention training for those teachers. But one of the things we're really trying to raise awareness of, because we have specific Norwalk data on this, but I think it's relevant to every community. When we did our youth surveys last year, we surveyed 3 towns. In only one were we able to, it was surveyed youth, right? High schoolers and middle schoolers. In only one were we able to ask about suicide directly, right? You can't usually. But in Norwalk, we were able to ask kids about suicidal ideation and also attempt and also number of attempts. So we were really able to get a lot in there. And just so you know, 13% of the kids from middle through high school had contemplated suicide, 6% had made an attempt in the past year. But when we broke down the data by the kids, we broke it down by like everything, right? We disaggregated it, but the highest risk group is not gonna be a surprise to you. It was the kids who identified as LGBTQ+, but 20% of them had made an attempt in the last year. So 1 in 5 had attempted. And so I think everyone knows this is a high risk group. There's not a lot of data out there like that. So that's what I want people to know. Also, it's not an insignificant group by far. This was, we had 18% of all the kids identify as LGBTQ and another 6% identify as I don't know. So like, and then there were some others. So basically there was only 70% of the kids identified as straight. So you basically have a large group with an incredibly high attempt rate. I would assume it's probably similar in other communities. So I wanted to share that data as like, you know, we have grants in to try to partner with Triangle Community Center and do a lot of really early prevention work around that population. But if we don't get the grants, maybe we do something regionally, maybe if the 80,000 comes through from DMS, Giovanna. So that was my data and my update.
Great. Thank you so much for that. It's really, really important. And I think exactly to just echo what you were saying, I think it's a known at-risk group, unfortunately, but to have that data and that actual evidence to support that is really important. I don't know if there are any other stakeholder announcements. If not, no worries, we can get into the guest speaker, but I do want to just kind of open it up in case anybody else has anything that they want to share or announce.
I think right now, this is a good time to ask folks, are they doing any training in our community around suicide prevention? Are there any planning or coordination around mental health first aid or assist, right? I think it's really important that we know about it so that we can promote it. For the hub, we have now started to do QPR training every month. What is it, the 2nd and 4th Tuesday? Victoria?
1st and 3rd.
Say that again?
It's the 1st and 3rd Tuesday.
Because of Narcan. First and third Tuesday of the month, and that is open to everyone in our community. But we're also getting specific requests from agencies to do professional development to staff. So if there is anyone that is doing anything around training, please let us know. So we can help coordinate and collaborate and also be able to promote your event as well.
All right.
Sorry. we are going to run we did a QPR a couple months ago. I mean, I did a bunch back in the fall in collaboration with you guys, and they were very poorly attended, right? But we did them. Did another one a couple months ago. We have one coming up that our clinician Karen is going to run. And so she's on vacation, so I don't know her date for it. But what I would like to do is try to put, like, yours are all in the day, right? So I think it would make sense to kind of have a schedule where it's like, here are the daytime ones and here are the evening ones. So I think Karen and I can try to put together a schedule of here are evening ones so that we can put them out there together. Gillian was just privately DMing me about, for more details on our anxiety support group. And I realized the other thing I should mention in case people on this call don't know is that we do have a young adult peer support specialist through our Turning Point CT project at Positive Direction. So Allie is the one who's going to join us shortly. But I want people to know that, she's trained as a recovery support specialist and a recovery coach. And we do have her available for a certain number of hours a week where she can work with young people around whatever it is they're dealing with. And then she, so if they are not in therapy, if they are in therapy, it's like a different service, and it's a real recovery, wellness oriented service. She has a lot of training. She's really good at it. And send people to her, because Gillian's question was like people coming out of the hospital, and especially we know if you're in the DMIS funded system and you're a young adult with some kind of severe mental illness, there are a lot of services you can get. And in the private sector, you can maybe find a psychiatrist or prescriber, and you can maybe have a therapist. And there's not all that other wraparound stuff. So peer support is really huge in helping people when they're at that point in their life.
Yeah, definitely. I'm actually personally looking forward to hearing more about the support group that you guys have later on. So I think that would be great to just hear more about and to kind of all be aware of. Sorry, my dog is throwing her bone around right now. Does anybody else have any updates at the moment? If not, we can move forward. But I do just want to make sure that everybody who has an update has the time to give it. All right, so it doesn't seem like that's the case. So I'm just going to briefly introduce Erin Mulhern, who will be giving, who is our guest speaker today. And she will be just kind of presenting on recent updated data and trends regarding suicide. For those of you who don't know, Erin is an epidemiologist. I'm not going to pronounce it correctly, but you know what I'm saying. For the
It took me 3 years to get that correct. Epidemiologist. Don't
Okay.
worry.
Okay, thank you.
We just say epi for short if it helps.
Sorry about that. For the state of Connecticut Department of Mental Health, she currently works in the syndromic surveillance under the Injury and Violence Prevention Unit, with primary responsibility to monitor emergency department and urgent care patient visits for changes to drug overdose activity, infectious disease trends, and other conditions of public health importance. She also stays busy outside of work by coaching her kids' rugby and softball teams. So I will stop sharing right now so Erin can pull up her presentation. And yeah.
Okay. See, as soon as I turn the presentation mode on, I won't be able to see you guys.
I can monitor the chat and see if anybody has any questions throughout the presentation.
Okay, perfect. And I think I need to switch these around. Sorry about that. Do you guys see the full screen, or you just see like the little screen?
So we can see the presentations, and the notes and everything, so we can see kind of everything.
I can't figure out how to, I'm sorry, I'm just trying to switch around the screens. Let me stop sharing and try this again. I gotta find where I put you guys. Okay, is that better?
Yes, perfect. You're all set.
Okay, thank you. Sorry about that. Okay. So thank you for inviting me to speak to you guys today. I'm going to give a really brief overview of what our syndromic surveillance and Epicenter platforms are. And then I have some data to show you guys that's specific to Fairfield County. And then as I show you this data, I pulled the details yesterday. So this is mostly real-time data that I'm showing you. And if you think of additional ways that you want to see the data in the future, let me know, because I can stratify the data in multiple ways.
And Erin, before I start trying to frantically record notes, will you be able to send us this slideshow?
Yes, definitely.
Thank you.
So I sent a version to Victoria already, but I made a couple of minor tweaks to it. So I'll send this one to you guys as well. So to start with, our syndromic surveillance system is a near real-time monitoring system that looks at cases of patients who go to either the emergency department or an urgent care center. The types of data that we collect is, sorry, my kid distracted me for a minute. But we're looking for any indicators of like an infectious or chronic disease or vector-borne diseases or drug overdoses that are occurring in real time. And then if we see those trends change, then we can start implementing prevention protocols and harm reduction protocols through our collaborations between both federal, state, and local health departments. And then this data is really a way for us to get data for in the moment for what's going on for public health. It's not necessarily confirmed data because that's what we get from our CHIME surveillance system. But this data is things that either the emergency department suspects is going on with a patient or things that a patient actually tells the ER, I am here because of this reason. And as you guys, I'm sure all know, sometimes a patient will go to the ER and say, I'm having a heart attack, but it's really a panic attack. So there is some discrepancies between what's really going on versus what we think is going on. Okay. The types of data that we collect for our syndromic surveillance, it's not identifiable information. So we don't have a patient's address or their name. We do collect the basic demographic information though for the visits, such as age, gender, race, and ethnicity. We also collect their date of birth, when and where they go to the emergency department at or urgent care. We can see the chief complaints, so why the person says they went to the ER, and then we also see triage notes, which are the notes that one of the medical professionals will type in as they're seeing the patient in the room. We also have initial ICD-10 codes that correspond to why the person says they're in the ER, and then we have the actual discharge codes. So whenever we look at data, we try to focus on the discharge codes. As of yesterday, we have all 30 emergency departments connected to our syndromic surveillance system, which is what these little H's are on our map. And then the pluses on our map are our urgent care centers. We have 37 connected right now. We'll have 5 additional facilities connected by June. And then we're hoping to get the remaining 38 facilities connected by this time next year.
Erin, are those urgent care centers that are like operated by hospital systems, or you know how there are all those like private urgent care centers like doctors and AFC and all those different chains, or like who are the urgent care centers you guys are doing?
So the ones that are currently connected are mostly associated with a hospital already. So either Yale, L&M, or Hartford Hospital. And then Hartford Hospital has 5 new urgent care centers, and those are the 5 that we're trying to get on board right now within the next month or so.
Okay.
The group that we're focusing on for the next phase are the private urgent care centers, like Physician One, and I think it's called Family Medical Center.
Mm-hmm.
And we tried to connect with them last year, and they said they were too swamped with COVID and they didn't have enough personnel to divert resources to this project. And that's why we had to postpone it by a year. And then once we get those new urgent care centers, a lot of them are like in this region of the state and then in the New London County area of the state. So we'll have better coverage from across the state versus just along the main corridors. Amelia, turn it down. Okay. All of this data gets filtered into an online platform that's called Epicenter. And state EPIs have access to this, as well as our local health department EPIs. So the data will go from a hospital to what I call a black box, which is what the vendor is doing for us. And it's a black box because I don't understand completely how all of these algorithms work. But the black box will look at the cases that come from the emergency department, and they'll tag them based on keywords and certain like phrases. And then those tagged cases will be divided up into Epicenter for us. So we can search for cases based on fever, for example. The black box tags every case that has a fever associated with it. So in Epicenter, I can just type in fever and I'll get all of those cases. And then additional, it could be like if it was a heroin overdose, the black box will tag cases with either an ICD discharge code that has heroin in it, or with a mention of heroin in the triage notes or chief complaint. So on my side, I don't have to worry about filtering through all the cases. They're already tagged for me to just pull up in Epicenter. As some of the keywords and phrases, I keep thinking of drug overdoses because that's the one that I was doing right before here. But everything about suicides, some of the keywords and phrases could be like a patient saying, quote, "I want to die," or someone saying, "I tried to kill myself." Those types of phrases would be classified as either a suicidal ideation or a suicide attempt case, depending on how it was worded. And then one of the nice things with Epicenter is that we always have some new word or new like topic that's coming up. And so even if we don't have a specific classifier for that yet, we can still search ourselves for keywords in it. So as of, I want to say, this is fairly new, like October, November of last year, we've developed some definitions specific for mental health, suicide ideation, and suicide attempt. So our mental health category, we're still in the process of finalizing it because it's picking up cases that are not related to mental health still, but it has about an 80% sensitivity. So out of 100 cases, 80 are mental health and 20 are unrelated to mental health. And this classifier is looking for things like schizophrenia, panic attacks. I can't even think of any examples off the top of my head, I'm sorry. Suicide ideation and suicide attempts are embedded in mental health as well. If you heard my earlier example about heart attacks and anxiety attacks, mental health is picking up the heart attack cases that are true heart attacks as well. And it's because sometimes people will go to an ER saying they're having a panic attack and it ends up being a heart attack. That's what we're trying to parse out for the mental health before it's completely done. Suicidal ideation is 90% sensitive. And then suicidal attempts is a little bit more sensitive than that. So it means that cases that are pulling up as these types of cases are actual ideation or attempt cases. And then we have some subclassifications of suicide attempt for asphyxiation and intentional overdose. Asphyxiation could be anything from strangling to bags. And intentional overdose is any type of substance that's used for overdose. So it could be an illicit substance, over the counter, or even a prescription medicine. We did have gunshots at a particular point, but we were pulling up a lot of homicide cases with that particular definition. So we've sort of excluded that from our classifications for now. Okay. And then these graphs on the side, they're just examples of what we can pull up in Epicenter. So I pulled these up at 9:45 today. So this first graph is a 3-week trend of mental health cases for Fairfield County residents. The second one is suicidal ideation trends for the past 3 weeks. And then this last one is suicide attempt trends for the past 3 weeks. And then if you were to be in Epicenter, you could actually click on your graph and you can pull up detailed information from your patients, just not names and addresses.
Erin, when you mentioned the intentional overdose, I just want to make sure you're saying that because of the way the syndromic surveillance is looking at triage notes and stuff, that you are able to say that these, 90-95% likely that these are intentional overdoses?
Yes.
Okay, that's huge.
Yep.
Right, because
Because
normally we're only able to talk about unintentional overdose and say that like 30% of them are probably intentional.
right. So we have an unintentional overdose classifier. And in that case, we will know that a person overdosed, but we don't necessarily know the intent because they didn't specifically say, "I tried to hurt myself on purpose." But for our intentional overdose, there's either like the patient said they did it on purpose, or there was another person with them that says they have a history of this and they've attempted it in the past, or they've discussed about trying to hurt themselves in the past few weeks. So those cases are being classified as intentional. And the ER is also putting in their ICD codes intentional to it. So some of our unintentional cases may actually be intentional, but there's no corroborating evidence to say otherwise yet.
Yeah, because that's where the research says that about 30% of the unintentional ones are intentional.
Mm-hmm. I know the OCME office, they're having some similar struggles with this. And it's for that reason. Unless a person who dies from an overdose leaves a note of some sort, they're classifying it as an unintentional overdose, even though a lot of them may actually be intentional. Any other questions? Okay. So the next set of slides is demographic information and some time trends that are specific to Fairfield County. I pulled up data from 2019 until March 9th. And so some of the slides I might cut off March data just because it sort of skews how the graph looks, but I still have the numbers in there in case you want to look at them. Okay. So the first slide is just suicidal ideation trends from the past couple of years by month. If you see this red line, this is when COVID hit and shut down the state, and everybody was afraid to go to the emergency department for any reason. And so I don't necessarily think that this trend is real and that people weren't having these types of thoughts at home. It's just nobody was going to the emergency department for it. Okay. And then, can everyone see my mouse?
Yep, can.
Okay, perfect. So I talk with my hands a lot and I can't do that this way. So I'll use my mouse. So our green line represents our 2021 data. And I have a suspicion that this is mostly due to teenagers, and I'll explain that why that in just a couple slides. But suicide ideation visits were pretty steady for the first half of 2021 with the low in August. But since August, these cases have started to really increase in our EDs. And I guess October is a normal spike for this type of activity. You can see in previous years, we've had that same type of spike as well. And unfortunately, it looks like previous years that spike continued to decline, but 2021, the end of it, we did not see that typical decline. And if you look at January and February of this year, you can also see by looking at the previous counts that we've seen more suicide ideation related visits already this year than we have at the same time in previous years. This slide is showing our active suicide attempts by month from the previous few years. And I'm going to explain this slide a little bit differently just so you have two ways of looking at the data. With this one, if you look on the right side, I calculated the percent changes in ED visits from 2020 compared to 2019, and then 2021 compared to 2020. And as you can see, some months there's been no net change. Like May, for example, between the past couple of years, there may be some fluctuations up or down, but there hasn't actually been an overall change between these types of visits in May. But if you look at September, for example, we are seeing some significant changes from previous years and increases in these types of visits. Okay. Any questions with these two slides before I show a scary slide? Okay. So this slide, there's a lot of data on it, and I don't expect you guys to look at all the data at this moment. It's really just a way, though, for you when you go home to look at these slides. You'll have accounts from the previous years of all the towns in Fairfield County who actually had a patient who went to the ED for a suicide ideation related visit. You'll have totals for the town. You'll have rates for 2020 and 2021. And these are both calculated based on our 2021 population levels. and then you'll have percent changes as well. And the main take-home point with this slide is that some towns are affected more than others, which I'm sure everybody already knows at this point, but now you have some numbers as to how Fairfield, for example, has a bigger change in what's going on with its residents compared to, say, Weston. And then this slide is the same types of information, except these are all suicide attempt visits. And again, you'll see that some towns like New Fairfield are seeing a significant increase in their current trends than we'll say Norwalk, for example, or even Reading.
Erin, can you please go back to the slide before really quick? Thank you.
Sure.
Okay, thank you.
And then I guess I'll note some of these I have to change to S. I'm sorry I didn't catch that. Like we're supposed to suppress counts 1 through 6 just to help with confidentiality. But if you see in this slide how there's S's here, it's just because the counts are between 1 and 6. If I could leave the total though, I did. Like this one, it would be really easy to back calculate how many suicide attempts occurred in Newtown this year already. So that's why there's an S on the grand total.
Got it.
Okay. The next couple slides are the demographic information. So our first one is, on the left side is suicidal ideation visits. On the right side, that's the way I'm looking at it, suicide attempts, and it's by gender. So overall in males, you'll see that males are having fewer SI visits and fewer SA visits going from 2019 to 2021. But this is not the case for females. Females have increased in both their suicidal ideation visits as well as their active suicide attempt visits. And if I remember looking through my research, you guys can tell me if I'm wrong. I'm still new to this part. But I think it's normal for females to have higher suicide ideation visits and males to have higher suicide attempt visits. So it's a little interesting that this trend is different.
I think the trend is usually that females attempt more, but males complete the suicide act more.
Okay. So I guess one thing just moving forward with this is that we would have to pull out trends from the OCME office to see if males are having a lower, I don't want to succeed. I'm struggling with my words, I'm sorry.
Great, but yeah, because like this data is consistent with what we know about ideation and attempt. But yeah, if you looked at OCME, you would see if men are killing themselves more than women, which is the traditional trend, or if it's a female problem all the way around.
Okay. So if the male deaths are decreasing, then we can be confident that this is what's actually going on from the OCME office. But I don't know that at the moment, but I can find out if you guys are interested. The next slide is looking at suicide ideation and suicide attempt visits by race. And I'll start with suicide ideation. So on the surface, it looks like overall with the Black population and the white population, suicide ideation visits are decreasing. I kind of say this with hesitancy though, only because if you look at our other race where it's showing an increase. Go ahead, baby, it's okay. Based on some data from the recent census, it looks like more people are identifying themselves as other race just because they have, a parent who may be Black and a parent who's white, so that person is seeing that they're another race instead. So this is a category that we're going to watch for the future. I'm sorry, my kid is 2. Amelia, can you go help her put this on, please? Thank you. I have an 8-year-old, a 5-year-old, and a 2-year-old, and they're all home today. Okay, so sorry about that. So other races, people are more likely to identify themselves as other races And I'm not sure if that's being seen in the ER yet, but it is being seen in the census data. So we'll have to keep an eye on this moving forward. I also included American Indian and Native Hawaiian percentages down here. Their counts were really low. I think it was, I don't remember exactly off the top of my head, but I had to suppress it for each year, which is why I don't have them on the chart above us. But there are some changes with the American Indian population that I think it's better that people be aware of now, just to start monitoring it now. I don't think we have a, well, we do have a high population for that, but I don't want anybody to be left out when we're trying to do prevention work. And then if you look at our suicide attempts, the African American population actually had higher attempts in 2021 compared to last year, whereas the white population did not. So that's a difference to note between SA and SI visits. And then otherwise, our other races have remained fairly consistent from year to year. And again, that could be because other years they weren't identifying themselves as other yet. Okay. The next graph is showing the data by ethnicity. And for suicide ideation visits, there hasn't been too much of a net change between Hispanic visits and non-Hispanic visits. And then looking at suicide attempt visits, non-Hispanics had an increase in 2020, but that rate has, or sorry, that percent change didn't fluctuate from the next year. Any questions on these last two slides? Okay. And then the last slide I have for you guys is showing the data broken down by age. And this one I'll adjust a little bit before I email a new version to Victoria. And it's only because I can put the percentage changes on them as well. But if you look at 20 to 59-year-olds, for the most part, we've seen either consistent or decreased SI visits in these age ranges. We have noticed, though, even with our OCME data, that the older adults are starting to have increased suicide ideation visits. And then we've seen some significant changes in our 10 to 19-year-old population as well. And this population is why I suspect that the increase in trends between August and October was primarily due to increased activity in teenagers. But that's someone I still need to parse out to be sure on. Okay. And then I think you guys all know this as well, but August, that was the first time that a lot of students went back to school for the first time since closing down for the pandemic. So if you look at the next slide, our suicide ideation visits, you see the same types of trends. Our 20 to 59-year-olds are having fewer ED visits or relatively stable compared to year. But our older populations are having increased suicide attempts. And then our teenagers are also having higher numbers of suicide attempts from year to year as well. Any questions on this slide? I guess I'll make one more comment too while you guys are thinking, I'm sorry. When I was looking at the data, I did not see any, wait, I guess I should rephrase. There was a suicide attempt in like 8 and 9-year-olds, but there were maybe like 3 to 4 for this category. But for suicide ideation visits, I want to say there were more like 50 or 60 8 and 9-year-olds who were seen at the ER for a suicidal ideation visit. And even though I don't have them listed here, their trends have been increasing as well. And I was actually able to look at these cases since there wasn't like 1,600 to go through. And some of them are misclassified as like an 8-year-old purposely jumped out of a tree and then hurt himself. So that purposely hurt himself was picked up by our black box. But I want to say about 70% of them, though, was an 8-year-old saying that it's hard to say because I have an 8-year-old, but that they were just not ready to continue with life.
That's so horrible.
I was shocked when I saw that.
Erin, I remember a few years ago, Norwalk Hospital had a 5-year-old come in after, I think, an attempt, not just ideation. What I'm wondering, I mean, we don't want any of that ever, right, at any age, but what I'm wondering is if we were looking at a 5-year trend going back further, like, this is all looking at data really from right before through the pandemic. Do you have any sense of whether like the numbers we're seeing now, or my guess is everything is higher than like 2017. I mean, I feel like we all know that mental health has been in young people has been getting worse for a while, but I'm not clear on like how much worse is it and how much do you think might be a bump from COVID? Was even the 2019 data already affected by COVID? I guess not. No, couldn't be.
So I was thinking about pulling data for 2018 for this reason, but we didn't have all of our hospitals onboarded in 2018, so the data will look pretty skewed.
Yeah. Yep.
I have 2 other correspondents. I have 2 other EPIs that I work with, and they work with the Chime data. So I can ask them to pull up like verified hospital records from 2016 forward and see if they can notice any trends in this.
I mean, it's not, we don't, we have to deal with what's in front of us. So I don't want to make any more work for anyone, but like, we've been looking at suicide data in the region for a long time, but it's really interesting and helpful to have ideation and attempt data like this. And maybe we don't need to go back further now, but maybe a year or 2 from now, we should look at a 10-year trend and see, like, are we stabilizing? Are we going backwards? Is it just a nonstop train ride up? So, yeah.
So this is definitely not my area of expertise, but my kids' school, they're doing a professional development today, which is why they're home. And their speaker today for the region is talking about reducing anxiety in kids. And she hosted a parent session last night. And she sort of commented on this because she was saying that teachers right now are saying that their high schoolers are acting like middle schoolers and the middle schoolers are acting like elementary school students. And she was saying that, I guess 20 years ago, there was a lot more interaction with kids. Like there wasn't as many screens. They weren't stuck at home all the time because parents are working, like just a different dynamics for society. And then just everything's kind of gotten worse the past 10 years because there's fewer opportunities for kids to socialize outside of home and school. So I wonder if that has anything to do with it as well.
Yeah, I would say that, so I'm from the mobile crisis of the Stamford, New Canaan, Darien, Greenwich area, and I've been working since 2018, and I definitely have seen such a dramatic change since the pandemic. I mean, prior, yeah, we would get a couple of those like younger kids who might have a bit of suicidal ideation, but nothing to this extent. And like the 5-year-olds that you had mentioned, Margaret, I mean, I just saw one like 2 days ago, and it's unfortunate, and they're struggling a lot, and there are a lot of wait lists. So kids like are having kind of even more symptoms and increasing before they can even get the help that they need. It's really sad.
Mm-hmm.
So, Janessa, I'm glad that you spoke because I was going to ask you, since you are mobile crisis for the lower county, what you have been experiencing and seeing, of course, in the line of work you do. But just when you have a youth and you know that there is a backlog in whether it be the hospital or not even the hospital, because that's just more of they're in a crisis at that moment. But when they do have suicidal ideation and there aren't any programs to place them in because of backlog, what is your second recommendation? Do you use our support group list to get them in to something that's a little bit more, supportive at their time prior to being in crisis? Or I'd like to just know a little bit more about what that process is, or even if you do that.
Yeah, so I would say that I believe my director, our director, Madeline Montilla, she likely does in meetings and when talking to the community, uses the reference provider list. As far as like the clinicians, a lot of times what we do is if we are assessing a child who has suicidal ideation and we of course know that there are a lot of wait lists, we are holding those cases. So we can hold them up to 6 weeks. And so we'll go into schools and homes and kind of try to provide that support until they are linked. The only barrier that I know that I'm kind of facing right now is 6 weeks now isn't enough. And it used to be enough. And so, I mean, I encourage parents, like if, you know, the child is still having some pretty severe symptoms, call 211 again, reopen that case. Like that is totally fine with us. And then bandwidth for our team is that we're only a team of 4. And so we do try to hold as many kids as we can and follow up in the meantime.
Thank you. I think I'm just still processing Erin's PowerPoint and the sadness that came from it because of, you know, these kids they're hurting. Everyone is hurting, right? Everyone is struggling for many different reasons. And it's always, and for us, it's always, what are we doing about it? How can we help more, right? You know, we're in legislation right now, right? Where Margaret was talking about having, you know, on Tuesday, there's a hearing for the CT-SAB bill to get them into legislation and hopefully dollars so that, you know, suicide, you know, dollars are backing up all of the work that we do, but how does it get down to the grassroots level? So I'm sorry, but my mind is just like kind of all over the place. It's frustrating.
I don't know if anybody has any questions or comments just based on the presentation and just have other things that they wish to discuss at this point based on that findings. I know, to echo Giovanna's kind of statement, it is, I mean, I think we all know that these problems are happening, but to have the actual statistics and data is certainly, one, sobering, and two, just saddening that so many people really are unfortunately struggling right now. But I don't know if anybody has any other comments or things that they want to ask Erin or just touch upon at this time.
Well, I think it's really helpful to have this information, which I haven't seen before. So thank you, Erin. And I guess, you know, putting it alongside of the OCME data would be useful to see, you know, who the people are who are dying now by suicide, and if they reflect the same, you know, if there's been any change in the ages or the genders or the races in our region in the last few months. Or, I mean, I know we have like annual data from last year, and we could obviously get month by month, but I guess maybe that would be something if you guys, or Victoria, if you want to at some point update some of this actual suicide data from the region with just like a little bit of a breakdown of, like, you know, through the most recent data, who is it, and putting it next to some of this ideation attempt data, because we don't want any of these things to happen, but like we were saying before, it's all basically unfunded. And so where do the prevention efforts, you know, something to help with what we prioritize. Erin, you are so amazing to get through all this with like kids and animals or whatever else is happening back there. I just want to say, like, I could never do it because my dogs bark like mad, but when my kids were little, I could never ever have done any presentation. My head would have exploded.
You're assuming my head's not exploding. I think my toddler, she's probably used to it at this point because she was 3 months old when the pandemic hit. So she hasn't known anything different.
It's like you, Giovanna.
Yeah. So, and she's only in
The
daycare
only-
now part-time because that was the first time that there was an opening in this whole stretch of time. It was 2 months ago something opened up.
The only blessing I have on my end is he's in music class, virtual music class right now. So when I'm unmuted, you might hear like singing, whatever else, or my husband singing or whatever. But, you know, that's the only reason why you don't hear mama, mama.
You're in good company. I'll ask Susan and Mike on my side to try and pull up some of the OCME data. For drug overdoses, we have a listing that we send out every month of all suspected drug overdose deaths. And that way people can get some, I don't want to say people, like health departments, legal boards, they can look at some of the details and figure out, is there trends going on that they see that we're missing and so forth. I don't know if we can do that with suicide deaths, only because there's so many.
Well, the suicide death data is available on the OCME website month by month, but I don't know. I haven't looked at it in a while, and I don't remember if it like tells you age and gender and all that. But I think it's just a matter of like, are all of us going to go and try to look at it and update our tables and graphs, or like, is that something
Right.
like, you know, can Victoria do it for our region?
Yeah, we were already talking. I actually, yesterday with my intern, she's going to be collecting the data within 2 weeks. So I already have her tasked to do that. So please no one do that for our region. We will, and if there's anything specific that you want, we can also add that, or at least be able to get that information for you. But typically with our data that we compile from OCME will be how many suicides just in our region, but then base it on each town who has experienced a suicide as well. Typically we don't put any demographics, but I definitely think that we need to, after this presentation, to make people, or at least provide awareness around the different populations that are struggling, and the emerging pops that are, you know, now that we're seeing post-COVID. Yes, Erin. I think Mike actually has assisted us in helping too with this. That'll be wonderful.
All right. If nobody has any other questions or comments, I can, there's just a few more points on the agenda that I can pull up and we can go through those. But as always, if you have anything that you want to talk about or share, feel free to put it in the chat or come off mute. But I do want to express sincere thank you to Erin for that presentation. Really important to see those numbers and just to be aware of that. So thank you so much, Erin, for taking the time to pull all that data and present it. We really appreciate it.
Thanks for inviting me. I hope it helps.
Definitely.
Mhm.
All right, here it is. Alrighty. So for the hub updates, I know we already discussed this. We are still doing our monthly QPR. It is on the first and third Tuesday mornings at 9. And as always, with all of our events, you can go on our website and sign up for it there and get the Zoom link, Zoom information. I'm sure it's, you know, a common theme. I think there's like a really strong uptick in the number of people who want Narcan trainings right now, which is great, but we're also trying to push the QPR as well because it's still really important, and to offer them together is great, but Narcan is definitely a hot commodity these days, but we're trying to make QPR the same way. So, and like Giovanna said, kind of any other trainings that are going on regionally, we can always help promote, push out flyers. What else? So legislative discussion and updates. I don't know if Giovanna, you want to talk a little bit about that, or I can. I know you had kind of mentioned it earlier. Oh, and also the Alternatives to Suicide Support Group. I do want to make time for that as well, because I know you guys. Do you want to do that now? Okay. All right. You guys can talk about that now. And I can stop if you have something that you want to pull up and share your screen. I can stop sharing.
I can only look at the agenda for so long. I'd like to see, our beautiful faces, Allie.
I hear ya. Sorry, I was like, I have my carpet being redone, so I was like navigating that right as soon as you called on me. I was like, of course. So I just like scooted right back. So hi everyone, my name is Allie Kernan. It's kind of complicated. So I work for a project called turningpointct.org. It is Connecticut's virtual wellness community for youth and young adults. It's statewide, free of access. We have resource videos, a social media presence and following, podcasts, things like that. So if anybody here comes across someone that's a young adult, and when I say young adult, I mean 30 or younger, we would love to have, if maybe they have artwork that they would want to submit, or they want to be part of a podcast or anything like that, we would love to have them on, and I can definitely help coordinate that. It's usually geared around like mental wellness or addiction recovery wellness, but we've really tried to turn it into more like, I mean, we even did a podcast recently that was like, what's it like working from home? Or what's it like, we're doing one on like dyeing your hair different colors. Like, so we just do like fun different things. So the project is, the turningpointct.org project is housed under Positive Directions, which is located in Westport. So my role is a little bit of both. I'm able to be part of that turningpointct.org project, but I'm also able to help Positive Directions with things as well, and also work closely with DMIS, Young Adult Services Department. And one of the things that we have been launching is my free statewide peer support that is for anyone under 30, and they can have virtual sessions, in person, depending, and it is on a limited basis, but right now I do have some openings and would be happy to take on more people. So that's just a little plug on that. But through that work, we found out that so many of the teens and young adults and just people that I've come across and work with or on meetings, there are very limited groups when it comes to suicide, where you can openly talk about having current suicidal thoughts, or maybe passive, or maybe past, really anything, and just kind of have a safe space to be able to share those things without maybe ending up in a psych ward or ending up in a treatment center. I mean, if that, sometimes people want that, but a lot of times some people just want a safe space to be able to talk about, like, hey, I'm having this thought, and when this crisis is going on, this is where my thought pattern goes. It doesn't mean I'm going to follow through with it, and it takes away the clinical approach, and instead it adds a peer perspective. So we have come across a grant that we can hopefully be involved in, but we're not really sure how we're going with that. But regardless, what we want to do is start a Alternatives to Suicide group. So I went, and when I first started working, I went and took a training through Advocacy Unlimited. It's through the Wildflower Alliance. They're located in Massachusetts, and it's basically a peer-run group where you can openly talk about suicide, whether it's having the thoughts and anything that I mentioned. So I got the training, and I kept saying, let's definitely make this a group, whether it's going to be, I even said I wanted to do it my personal time too, because it's really something I'm passionate about. And we decided that we were going to try to just launch it no matter what and go for it. So before launching it, I wanted to get some feedback from people that, hear a lot about suicide, are in the trenches of trying to figure out whether it's suicide prevention, diversion, whatever. I have just been trying to just get any information I can. Right now, I'm kind of just being a sponge to find out what opportunities are out there. And right now there is, I want to say 1.5 alternatives to suicide groups being run. And they're open to all ages and they're online. But the unfortunate thing is when you're doing it in person, the one that they have right now is all the way in Hartford. So how does that help anyone in Fairfield County? So I'm hoping to launch one in Fairfield County, and I have some ideas, but I just kind of wanted some feedback on what you think. If this is, I know it's a need, but like hearing that it's a need, if you think maybe it should be more focused on young adults, I kind of want to open it up to everyone, but just some feedback would be cool. And I'm sure Margaret would be able to help me more with more questions because I'm still navigating this, but kind of about like, where should I promote this when this group gets started? Should I change the language if I'm able to? Things like that.
So let's do one question at a time. So the first question, everybody, is if we're going to have an alternatives to suicide group, it would be in the region, serving this part of the county. So not even all of Fairfield County necessarily, like really the area, you know, kind of region 1. And we're thinking, despite the need in teens, that probably it has to start at 18 and go up from there, because we're thinking just even promoting an alternatives to suicide group to teens, you have to go through parent networks and school networks, and they're all going to flip out and say, you want to identify teens who are suicidal and you want to connect them to a peer group and not to like throw them in the hospital. So we were thinking it's probably 18 and up. The young adult population obviously has high suicidality, and then maybe we could throw in other ages, but let's start with that question and get your feedback. And if you think about the people you work with and who would you send and who needs it, and because there's like, who could use it and who can you realistically get there? And also anybody, if you pick a teen group, then you're definitely not going to have adults in there. But if we did 18 and up, that's why Allie was researching that the other groups, they are like 18 and up, or maybe they're 21 and up, Allie, I don't know, but they're like,
18.
they were
yeah,
commenting that there wasn't an issue if there was like a senior citizen with a young adult, that was fine for this content. So could you guys give us your thoughts on that age distribution?
I have a comment just really quick. I say start anywhere at this point. I think I get so many people reaching out to me personally because I lost my daughter, Abby, to suicide, and they somehow consider me a resource in terms of what to do. I don't have that professional background, but yeah, I have tons of, you know, again, parents as well as youth and young adults. We need this. We need to keep the conversation going. We need to open it up. And I find that the younger adults are seeking this kind of help. And a lot of times they're saying, my parents don't believe me. Like I'm, you know, so I don't know. That's just my 2 cents. Like start anywhere. Yes, we
Yeah.
desperately need this. So thank you.
Other
I do
thoughts?
think, I think that I agree with Gillian, not to have like an age cap or start, but my thing comes down to legality issues. If a youth under 18, sorry, now the light is going to start to change. If a youth participates in the group and then dies by suicide, what is the legality of that? Do you know?
It would
Based on
definitely
what-
be a problem.
Yeah, well, even so though, I think there are ways that I'm connecting with I'm actually meeting with them next week, the Wildflower Alliance, and asking them what they've done with teens, because they have had teens. And I think what I learned through that training, because I had all the same questions, I had like the clinical brain going in, but still like harm reduction and still open to it. But I was just concerned, you know, with everything that I've heard. And what I gathered from it was based on trainers that have been doing this for 10 years plus, of the thousands of groups they've ran, they've only had, and I don't mean to say only, but they've had 2 people follow through with an attempt. And it was when they weren't connected to the group. So, you know, when I kept hearing that, I kept thinking like, I think people are just so worried it's going to happen, but it doesn't. But of course you have to prepare for that. But a lot of what they found was that even when it came to minors, that the whole duty to warn and like mandated reporter thing sometimes doesn't always fall under the category of suicide. It's usually abuse. It's or neglect or something like that. And suicide is not considered in those categories, and that's when they have usually agency protocols. So a lot of times these groups are ran through harm reduction agencies or like community centers, libraries, things like that. So I can imagine if you are using harm reduction agencies, even harm reduction agencies have policies when it comes to minors. So if they're still able to somehow have that, then there's got to be either
A loophole.
a loophole or something.
There's
and
always a loophole.
I'm determined to find the loopholes. Okay, so
Don't worry.
don't worry
You
about
got
that. I
Margaret
will
on your
sniff
side.
it.
She'll find it.
Yeah.
Are you saying I'm shady, Giovanna?
Oh, no, you're
Creative.
No, you're
You're
persistent.
You're thorough.
But so the other, this is really good to hear because, Ellie and I were talking about this and we're like, so one issue is that kind of legality, liability stuff, right? And we are a behavioral health agency, and also behavioral health agencies in schools would be referring kids potentially. And I also think they won't refer kids, like schools won't. Schools aren't going to touch with a stick, right? But then the other issue is, I'm listening to you, Gillian, you're kind of like, just make it an open group. So then you could have teens and you could have grandparents. And then another question that comes to my mind is, will the teens go to the group with the grandparents? And I wonder about that because I do think young adults potentially would. And then what we heard when Ellie went and asked around was they would, because it's not a group where it's such a specific topic, right? It's not like I'm here because I'm stressed about the SAT. Well, I'm here because my spouse of 50 years died. It's suicidal thoughts. But I do wonder if you have a group like the 13-year-olds, Abby, or Gillian, oh God, I'm sorry, Gillian, but like the 13-year-olds, the 18, the 16, 17-year-olds, I feel like if they needed this group and they went into a group and people their parents' age and their grandparents' age are in there, I feel like they're not going to open up and it's not going to meet their needs or they won't come back. And so then genuinely it's like, who do we target? But again, seeking input, because obviously if we open this group, well, and I want to say we are going to open this group. We don't know when we're going to open this group, but we're certainly hoping the Regional Suicide Advisory Board is going to be a huge promoter and help like get the word out, because that's what we're all here for, right?
Allie, have you reached out to SOSA in Hartford to see what they have been experiencing? Because I know they started that group, I want to say a little over, I know they had to hit a year already, but probably about a year, a little bit longer. So have you reached out to them to kind of hear what some of their, positives and negatives are from the group itself?
From
Based on all
the current
the,
running group?
Hmm?
From the current running Alta Sioux group?
Mm-hmm.
Yeah, I did. So I talked to Toivo, which technically is the one that does it, but then I also did end up finally reaching the facilitator of the current one. And actually there's been one going on for years and she's been doing it for some time, which I was really surprised, her and someone else. But they said that the issue of the age gap isn't really a problem at all. That they tried to do a hybrid model when they were transitioning from pandemic fully virtual to in person, and they found that wasn't very good because people on the Zoom would talk and then people that in person would talk and it wouldn't work well, because I originally was thinking maybe a hybrid, but they're saying that people are coming and people want it in person, and that there's a consistent amount of people coming every time. I forgot what other question you had of that group. Did I get them all? I don't remember if I got it out. I think you asked another one, but it's not coming to me.
I'm realizing this is, before we go into more questions about this, and we're really grateful to you guys for input in this, we should point out, if you guys, when you're doing suicide related work, we should all be letting everyone know that there is the online Alternatives to Suicide group that's run by Toivo, right? Because that's open to anyone, it's online. And NAMI Connecticut through their young adult groups. We realized yesterday they are currently running a weird kind of, but interesting sounding hybrid group. If I could share my screen, if you guys make me co-host, I'll show you. It's aimed at young adults. It's building in alternatives to suicide and an online gaming model that like, so it's really for people who do a lot of gaming. And I forget what it's called, but it's like an out of the darkness type language. It's a video game that helps you process your depression. And so they literally list this group as being for people. They're like, it's a Dungeons and Dragons level 5 plus
Yeah, it
alternatives to
was weird.
suicide.
It was different. I was like, wait, this is an alternative to suicide. For a second, I got nervous and I was like, oh no, I just said that there was one meeting. And then I was like, oh wait, hold on. They added like a gaming component, which actually was really good for a lot of teens and a lot of kids and a lot of young adults that I know that are really into gaming, because that might have been that avenue of like kind of opening it up. So that was exciting.
I'm trying to find the definition for you. I'll find the description and show it because, yeah, and it's not that they like invented it, right? Like it's,
Right.
they're combining Out of the Abyss is an online adventure program. Wait, can I share? Here we go.
Yeah, there it is.
Here it is, Out of the Abyss. So check this out.
That's really cool. I know a lot of the teens that I do see, their only coping skill is video games.
Gaming, yeah.
Yeah, so
Yeah,
that's
same with some of
amazing.
mine. Yep. Perfect. And you know, like, I know when I listen to my little cousin and I hear him in his headset, like, they're bad, like they're bad, some of the stuff they say and like hear, and it drives me crazy. I'm like, I'm thinking like, I know that's virtual, but like that's bullying and that's really bad in your ear, and that's still messages in your subconscious like that are negative, even if it's not at you, you're still hearing it towards someone else. And you know, there's such thing as like seeing someone else's trauma. So I think having something good in their ears and their headset, well, because gaming can be a safe coping skill, you know, but I agree with you. I definitely think it can get
All with moderation,
started.
right?
Right. Except for dogs. Dogs, I don't believe there's moderation for having a dog, or like
Yes,
how much
there
time you
is.
spend with your dog. No.
Yes, there
Refuse.
is.
Nope.
No, yes, there is.
Nope.
So going back to the last thing we're talking about was about teens being in a group with people that are like middle-aged or seniors. What do you guys think? And Allie was saying the young adults and the elders, that doesn't seem to be a problem. But do you think if we want teens to be in there, will it work as an all ages group? Or if we want teens, does it have to be a teen specific group?
So mixed on that. I think that a lot of teens have problems with talking in front of teens. So teens talking in front of adults also may be challenging. But I think it might be, the way that I phrase it a lot for like group therapy is like, it's people your age who are struggling with the same exact things. And I think it would be harder to kind of promote that if it was like a larger span with other like adults. But then it could be kind of a nice thing on the other side, because it would be like people who have overcome maybe some of their suicidal thoughts or feelings that they had, and being able to kind of almost like a mentor-ish, like explain and share their story, which also sounds beautiful. I also think that parents of these teens or kids or whatever age might be a barrier in whether they would allow them to be in even if it's an alternative suicide group. I think a lot of parents get concerned, especially like IOPs, they get concerned about like, yeah, but they're all going to be talking about their issues, and they get really worried about, is this going to make them think more about suicide? And we try to break that down, but it's not always effective. So I'm mixed, sorry.
I think we're all mixed probably, but thank you.
yeah, I'm definitely mixed because there's a part of me that, you know, wants to keep it like maybe like 30 and under, or like 35 and under, or something like that. But then there's this other part of me that's like cutting it off. I don't know. It's tough because I've started a lot of teen groups, and what I found was older young adults end up needing it, and then it's like, or the regular adults end up needing it, and then I'm like, great, no, there's not something for this person, but it's still something I'm battling, I guess.
Have you talked to Jeff Santos, Santo at Ripple? I remember him talking about a couple months ago, talking about how he's been collecting data on people that have been going to his late night support group,
Yeah.
and how a lot of them are experiencing suicidal ideation, and he's been really supporting them. So I'm just wondering, based on that data, what ages is he? Say that again, Margaret.
No, I'm just, yeah, it's a good idea to check in with him.
Yeah.
I know he talked about it a couple months ago, right, Victoria? So maybe that would be data to at least base your decision on. I know it's not the, you know, long-term data or anything, but maybe based on his recommendation or comments, his experience.
Yeah, for sure. He's definitely on my list.
Yeah, I will just echo that he's a really great resource. I met with him a couple weeks ago now, but I know he's still very much kind of compiling, so to speak, that data. He's still getting people who, you know, will call him and come to his groups. And even honestly, just for like promotional reasons, I'm sure he would be more than willing to, you know, refer or divert people to that group. So I would definitely, yeah, just recommend. And I mean, I know Giovanna just said this, but I think he's a great resource. So
Yeah. And Margaret knows him too, so longtime colleagues.
Yeah, Allie knows him too.
Oh yeah.
Yep.
Yeah.
So Victoria, I know you have a couple other agenda items, but can we ask a couple of quick questions that are more on the like, what was it, Allie? It was more like, there was a marketing question and a dissemination question. Was that it?
But some of them got answered, like referral networks, if you know how it can be distributed to where it would be. And I mean that in like, you know, I know this is a safe space to be able to distribute it and know that it will get in the hands of the people that need it and will be explained in a sense of, no, this is a helpful thing, not a scary thing. So I'm just wondering what other places would you recommend, and would you suggest, and I haven't checked with Wildflower Alliance if I can change the language yet, but because they might require me to like put the official alternatives to suicide. So, but if there is
Wait,
an
because
option-
you're alluding to the question that we wanted to ask though, because you're saying we don't know if we can change the language of it. But I guess one of the questions was, this has come up before, is like, you know, if you call a group alternatives to suicide, that is genuinely what it is. People know what it is. But we wanted to see if there was feedback from this group in terms of, if Wildflower will let us say whatever we want to about it, is that going to be even remotely acceptable? Or are people going to run screaming away from the concept of it? Do we need to have like some kind of language to soften it? Do you feel like there would need to be more of an explanation? Ellie, are you able to share the flyer that's out there? Do you have that to share?
I don't have it. It's just alternatives to suicide, Toivo. That's all
Okay,
it is.
because we were trying to get the flyer that they
Pretty
use
basic.
to share in the external community to show you guys, to get your feedback on how the group that exists is advertised, and see if you guys had any thoughts on like change it, you know, that type of advertising will or won't work. But if we don't have that yet, maybe we can send it out later and you guys could give us some thoughts, or run it by potential clients, potential participants in this group, and say, you know, I would have questions, I would want to know more, I would have concerns. I think that would be helpful. But yeah, so sorry, then Ally, so your question then is how could you guys help us disseminate this, and where would you recommend?
Hospitals. Other support groups.
Yeah, hospitals was my first go-to. I even asked Toivo, are you connected with the hospitals? And they were like, that's a great idea. I was like, what? Like, what do you mean you're not? What? But yeah, they said, but they've mentioned, you know, their relationship
Global
with
crisis.
emergency rooms hasn't always been positive and welcoming and receiving. So my suggestion was loopholes, get in contact with any recovery coach ED, because even though they focus on addiction recovery, they'll at least give a resource for mental health. So, you know, in that moment to be able, like, if they have like a little packet they give people, I don't know, to say like, hey, if you ever
EMS.
struggle, right.
Sorry, just keep on.
Yeah.
I'm just gonna keep throwing.
Yeah,
I know,
no, that's great.
I'm like waiting for Lee to say, EMS, we got this.
I saw Lee's name and I said, EMS.
I think with hospitals, like Ali said, we probably have to get creative because some of that, you know, they have to understand it and they, you know, they're all going to go to liability, right? But I think provider networks and peer support networks and schools, I would love to have schools share this. I think that's going to be very tricky.
Very.
Like virtually impossible. I think parent networks will be very scared, and that's why the language on the flyer is going to matter. So when Ellie gets the existing flyer that is used upstate.
Yeah, so I just found it. It just says alternative. It's a really, I tried to put it in the chat, but it wouldn't let me. It's like a stock photo that just says like of people linking. Oh, sorry,
Can you share your screen and we can see it?
Yeah, I mean, it's not Toivo specific because Toivo actually doesn't have a flyer now. It's not posted. It just goes out in their thing. But this is the one that I've seen that they use. Great. Hold on.
I would even say first responders, anyone
There you
that
go.
is
So
really,
it's really basic.
or even dispatchers, right? At police departments, you got Catalina, who's embedded in Stanford
Yeah.
Police Department, right? So just, you know, and it's going to be rough in the beginning, you know, in kind of establishing the group, right? Just people being more aware or self-aware of what this group is, what is it about, you know. When you talk about alternatives to suicide, folks may be like, hey, you want to actively talk about your suicidal ideation? I don't know about that, you know. Even though it is a support group that potentially does and can help others. But I think in even having statistics around this support group and how people have, how has the group supported individuals is going to be helpful. So if there is some type of data behind this group, you want to have that. And of course, evidence-based. Whenever you have that, you know, a lot of social workers will then be more inclined to support it and refer out.
Yeah.
I think that's a great idea. And I'm also thinking if anyone who has been in one of the groups or facilitated one maybe and is willing to talk about what is, you know, because you could have a nice little short video that's like, what is this? Who is this for?
Yes.
Demystify it to make it acceptable for people to go because it's a scary thing.
Yep.
Yeah.
Allie, thanks for sharing this. Like, you guys, if you have any thoughts on that language that was on the screen, I didn't mean for you to take it away because we didn't talk about it, but like maybe screenshot it or send us comments, or did you like that language that they used to
Share it
describe
back,
it?
please.
I mean, this was just a general stock photo that people were randomly posting.
But
and
it's
this
the
isn't-
language. It's like,
it's
what do we think
just
about the
pay
language?
attention to this, not the dates or
Can
anything.
Victoria, can you screenshot that at least so we can put it in our minutes? So if those that couldn't make today's, those that couldn't make today's meeting, if they do have any input, they have this picture.
Yeah, just have them have a note that just pay attention to the picture and not everything else, because I have no idea who any of this stuff is. I just have seen this within Toivo, and I've seen them just add their logo right here.
Okay.
And maybe Victoria, maybe it's just that line, that paragraph underneath where it says it's non-judgmental, non-clinical.
Oh boy, oh, here's a whole
Right,
little
so it's,
detail
so
thing.
it's all of this maybe it's just, you know what, Ally, why don't you just put the link in the chat? And then everybody could just open it up and tell us what you like or don't like about that kind of language. If you think it would be helpful in getting people to understand and attend, or if it would scare them or whatever.
Well, thank you everyone for your feedback and welcoming me in here. I really appreciate it. Even though many of you, I know your familiar faces, but it's nice to see you. And yeah, thanks for the feedback. I'll definitely got it all here. I appreciate it.
Giovanna, you're muted. Sorry. No one can hear you right now.
I was wondering, it said end meeting. I'm like, no, I don't want to do that. What's going on here? You would think 2 years later we would be pros at Zoom, not challenges constantly. No, I was just saying to Allie, really excited to hear that you are moving forward with this group, and any way that the hub can help in promotion, possibly even support you in any which way, whether it be, I don't know what our funds will look like at the time of you, getting this group going, but maybe even coffee or, tea or, something, just to get a crowd or at least a couple of people to the group. So we can talk a little bit more when that time comes. Again, I don't know what our funds are going to look like, but I will hope that we will have some dollars for you.
Awesome. Yeah, that would definitely help gather some people and would be welcomed and appreciated, especially since I'm a tea drinker. So myself would actually love that. But yeah, I'll put my email in the chat in case people don't. Oops, I almost put my personal email. I swear I always do that because they both have
I
my
think
first and last name.
put your email in the chat, and I think that will help. If people do have questions afterwards, they can reach out to you directly about it. We'll have that in our minutes as well. We will push this out, the minutes and Erin's PowerPoint, once we get hers updated on our end, because I have 9 minutes and I'd just like to end it discussing legislation and to talk about a couple of hearings that are coming up. One is on Monday, we have the public hearing that has several really important bills that they're going to be addressing on that day. And one of them, you have vaping, opioids, suicide prevention, you name it, it's all in this one day. It's exhilarating, but then also stressful and tiring, because if you're like us, we're trying to write multiple testimonies and testify on all of the bills that are related to ATOD, suicide, and mental health, things like that. But I sent out an email late last night asking a call for action. One of the bills that is going to be discussed on Monday is our BHAO bill. Excuse me, of course my computer just went down, so I can't give you the bill number. 1 second, please. Oh, come on. It's Friday. Yes, it is.
Giovanna, if I'm correct, I think it's bill number 5419, an act concerning the Department of Mental Health and Addiction Services recommendations regarding regional behavioral health action organizations.
Yes. Thank you. So that bill right there, we are looking that all of our stakeholders or anyone that really has worked with us in the past really submit testimony or testify on behalf of us. I also did put some talking points to make it a little bit easier for you. I already I put in the committee names and things like that so that you all had that information. So please, if you can, if you have some time, we're looking to have you support us in this bill. Really, the bill is to put us into legislation. Historically, we used to be in statute under Regional Action Council directors and Regional Mental Health Board folks. And when Demas decided to restructure us back in 2017, we're out of statute. So we really want to make sure that we're in statute, just like the RACs and regional mental health boards. So I'm hoping that this time it will get passed into legislation, because it's been since what, 2018, since we've been fighting for them to include us again. If we're not in statute, that just means that after our contract, we potentially may not have any prevention work, which means then we wouldn't be funding local prevention councils or providing a strategic partner, being a strategic partner, or providing mini grants of any sort, or Narcan training, QPR trainings, anything that we have done to support all of you in the great work that you do. So I'm hoping that we will have some supporters to submit. Another thing is on Tuesday, we have the Connecticut Suicide Advisory Board a bill on Tuesday. That hearing is happening. Thank you, Margaret, for putting that in there. CTSAB, actually, I don't know if they have sent it out to all of their subscribers yet, but once I hang up today, I'll reach out to Andrea Duarte and the chairs to see if I can send that to you as well. They created a one-pager of talking points for Tuesday. And again, it's just an easier way just to formalize what the bill is about, what CTSAB is, what their passion is, right? If we get legislation and have CTSAB there, then that means the state has to provide some type of prevention dollars, and in hopes that it'll trickle down to grassroots level. So that's our hope, that we will have them in play by the end of the legislative session. Margaret, did you have anything that you wanted to add or say about Monday and Tuesday? You're on mute.
I'm sharing my screen because, as Giovanna said, there are so many bills at the hearing on the 14th before the Public Health Committee.
Monday.
So, yeah, I'm sorry, I meant Monday.
You said the 14th and I just said Monday. That's all.
Oh, good. I gotcha. So in the action alert she sent out yesterday, she highlighted a bunch of these. I just want to make sure everyone also knows there's some other stuff that's important to the mental health community, like this one, prohibiting some of the health insurers from requiring step therapy, which is where they, like, if someone has, whatever need for mental health medication, sometimes they force you to go through, like, try this one, even though you think in the past you've tried it, it didn't work for you, and then try this one, and then try this one. And you kind of have to exhaust all options before they'll reimburse you for the thing that you might have known you needed, your prescriber knew you needed in the beginning. And there's also this one about expediting licensure to allow out-of-state providers to work here, which is relevant sometimes for things like people who go to college in another state, right? And so there are so many things happening on Monday that I wanted to point out that if you're feeling like overwhelmed, but they're all important, you can submit testimony on each one, and it can be like a paragraph. You can just go, I really support this because I work in the field and blah. You can also write one testimony, and I mean, you wouldn't be able to talk about all of it in 3 minutes, but when you write your testimony, it can be as long or as short as you want. You can include links to other people's testimony. So you could have a link to the CT-SAB testimony. But like, I'm looking at it like it's so much stuff. I might just submit one testimony that's like on the prevention bills, and I will say, you know, dear Rep Steinberg and blah, 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 you know, I'm here just to testify on, and I'll list all the prevention ones and say, support, you know, comment, you know, oppose, and then write my comments and then do one on the mental health side. So I just wanted to let people know, because I feel like everyone gets overwhelmed with how many bills there are. You can combine, I mean, because it's all in one committee. So you can combine, the way the Public Health Committee traditionally works is they go by agenda item, right? So whatever number, wherever on the agenda each bill is, they try to hear all the testimonies on one subject at one time. But if you're submitting your testimony in writing, don't feel like you have to submit 10.
Thank you. Yes.
And I'm definitely going to be talking about the need for money for prevention. I think like all of us commenting that there is no money for suicide prevention when they're all, you know,
Well, you know,
all purposely, all noticing the mental health crisis for the first time.
I think that, you know, it's interesting because we got the ARPA dollars, right? And to really focus a lot of our efforts on mental health, especially with the local prevention councils, received almost half of what you would receive with your regular pool of local prevention dollars. And that's it. Well, 2021, 2022 fiscal year is not going to fix, you know, what our state is enduring, right? So we need to have those extra dollars. And I know that I continue at the state level just to say, you know, our numbers are increasing. We need more support. And what does that look like? So to be continued, of course, but I think to just follow up, we'll make sure that we get you the minutes and the recordings, just in case you want to, yes, that bill, the 317, HB 5420, we will be submitting testimony as well for. We'll also send out a hub priority bill that we are going to be following and submitting testimony. So you see that we are on our end advocating as much as we can. Unfortunately, there's so many bills that we really need to hone down on what we are doing, because like you all know, we're stretched thin as well, even though we have a team. Just like you, just like us, we're all being overworked at this point. So yeah, so we'll send that out as soon as possible. Hopefully, if we can, by the end of today. Yeah, depending on Aaron, actually, I should say. Unless Aaron, you think unless you think we can just use your PowerPoint that you already sent us.
She actually emailed me a PDF version already, so we're good to go.
Man, you are the bomb, Aaron. Thank you.
It's like, if I don't do it now, I'm going to forget.
True. All righty. Well, I think, Victoria, we can say our goodbyes.
Thank you all. Have a nice weekend.
Guys, you
Take
too.
care.
Watch out for the